Thank you, Chairperson. Good afternoon, everybody. I'm going to speak about new insights in the management of heart failure with improved ejection fraction. This talk is based on a recent paper which is published in American College of Cardiology Journal recently, looking into the different aspect of improved heart failure population. So this is the outline. I will be discussing about the definition, epidemiology, pathophysiology, management, and future uncertainty about this condition. What we have learned so far, that heart failure with ejection fraction occurs in a patient with generally HFimpEF, and those who improve, they are generally in a state of remission rather than in recovery. So, and because of that, they have got improved prognosis compared to persistent HFimpEF population, although they have a fear of relapse rate, and current guidelines so far says that we should continue GDMT indefinitely for this population. And let's discuss about that. So what is the definition? Different organizations, different societies have given different definitions. For example, the Universal Heart Failure definition said heart failure with baseline LVF below 40%, a 10-point increase, and a second measurement should be above 40%. And then came the ACC guideline. We say that less than 40 and second measurement above 40. They did not mention about the point increase. And the ESC guideline, little different. They say less than 40 and second measurement should be above 50. So that is the difference between the three guidelines. And what we have seen, what is the prevalence of this heart failure with reduced ejection fraction? It is somewhere between 20 to 40%, on average 30% over a period of 1 year with use of the 4 pillar of drug. And generally they have, as I said, they have a very good prognosis, but a persistent risk of relapse is there. So if you compare the prognosis of the patient with HFrEF versus patient those who got improved heart failure, what we found that there is a 50% reduction in hospitalization for heart failure, 50% reduction in cardiovascular mortality, lower arrhythmic risk, and even sudden cardiac death. But long-term follow-up have shown that they relapse. So who are those patients? Those who show improved ejection fraction. What are those people? Those who show reverse remodeling and improvement in their ejection fraction. So many clinical trials have been done in the last few years, and out of the major 9 trials, what we learned, conclusion was, the people, those who are younger in age, those who have got non-ischemic etiology, shorter duration of disease, better myocardial functions on the echo, and decreased biomarkers, better kidney functions, less comorbidity, those who are on ICD or CRT or MTR, as just Nagendra has shown you, female sex, and less fibrosis in MRI. So these are the group of people with heart failure, those who have got associated evidence of this finding, they are more prone for improvement in ejection fraction compared to the patient, those who have constant heart failure with reduced ejection fraction. The other area, there was a research which went on to particularly for non-ischemic cardiomyopathy population, and they found in dilated cardiomyopathy population, 30 to 40% people, they have genetic. And genetic TTN, LMNA, these genetic mutations also guide us whether this patient is going to improve his ejection fraction or not. And then there are certain genetics in this subgroup population, those who give us certain more genetic information about LMNA or FLNC genes, which are more prone for arrhythmias and sudden cardiac deaths. So so we have to incorporate genetics also while discussing the management of improved heart failure population. So far the data about the heart failure with improved ejection fraction came from a very small study on only 51 patients, the TRUD heart failure trial, where they found that if you stop GDMT, there is a 40% relapse rate. And most of the time relapse rate is asymptomatic. So what were the implication of the TRUD heart failure trial? That there are a subset of patients, those who still have recovery, even if you have stopped the drug, they continue to have a better ejection fraction. The predictor of the relapse were those who have very high NT-proBNP, those who have got genetic variation, and the de-escalation strategy is slower or partial de-escalation of GDMT might be safer but requires more research. So this was the study which was, and this TREAD heart failure trial was done only in non-ischemic cardiomyopathy patient, not on ischemic cardiomyopathy. But it did show that we should not try to de-escalate the therapy for every population. For the management of improved heart failure population, those who have reached that stage, they are already, most of them were on 4 pillars. Some of them, because of worsening heart failure, they were on vericiguat, they received iron therapy. They also had ICD and CRTT and LVB pacing, and also mitral H2H repair in certain patients with secondary heart failure. Before the ARNI came, we have data from all other drugs like ACE inhibitor, ARBs, beta blockers, that, or even the devices, they have shown that most of them, they work in a positive manner, they reduce the LV volume, they increase the ejection fraction. But when the ARNI came, after the paradigm heart failure trial, there was a significant improvement in this type of the reverse remodeling population. And there where we started judging that there is a condition called improved heart failure. But there are only 2 studies at the moment, those who have looked into this entity of improved heart failure population. The one was the DAPA heart failure trial, where dapagliflozin was used over the baseline heart failure treatment. And second was the heart failure in fine arts heart failure trial, where they've used finerenone in improved heart failure population. And both the studies showed that when they included this group of population in clinical trial, over and above the baseline heart failure treatment, there was further reduction of cardiovascular events and mortality. So that shows that SGLT2 inhibitor and finerenone probably for this group of population will be a better drug, maybe better than the spironolactone or better than eplerenone, we don't know, but the future trials will give us. And we should also try to look for identify the patient, those who can have high recurrences of relapse. And these are the people who are phenotypic patients, those who have got high biomarkers, have advanced imaging problems and genetic testing. So there remains the unanswered questions, clinical uncertainty. Let me discuss that. So one is that they say that only looking at the ejection fraction may not be a good idea. We have to go for global longitudinal strain. And this has shown that it is more sensitive than LVF for systolic function and prognosis. Abnormal GLS less than minus 16% demonstrate a high sensitivity and predicting a subsequent relapse. So if your GLS is low, then I think we should try to avoid de-escalating the therapy. MRI, late gadolinium enhancement shows a significant quantity of myocardial fibrosis, and T1 mapping and microstructure feature of the volume expansions are also very important indicator in MRI. Biomarkers, NT-proBNP has been seen, and now we have ST2, which gives you a prognosis. The fibrosis of myocardium, probably these 2 biomarkers will be useful in predicting the future relapse of the disease. So GDMT de-escalation, how to reassess? So this is a situation what we say for select patient with full resolution of myocardial abnormality, partial GDMT de-escalation is an emerging hypothesis. So how to go about that? I think ongoing clinical trials are going on at the moment called Bonfire study to reduce the beta blocker first, the TREAD heart failure 2 trial where the MRI they are going to reduce, and then subsequently they will try to reduce the SGLT2 inhibitor. Probably we have to wait for the result of this trial for another 1 year. But what we learned that de-escalation is possible if you have low NT-proBNP, normal CMR, not significant fibrosis, and a significant improvement in GLS. But again, the message is, I think there should be a personalized approach. But it is possible we can de-escalate population in certain subgroup of population. But there are etiology-wise also de-escalation specific cardiomyopathy, which they have said peripartum cardiomyopathy, a significant number of patients, they improve significantly. Probably there may be a possibility after a few months to de-escalate the treatment. The Tokosubu, again, there are subgroup of population, those who have shown complete recovery, normal coronary angiograms, and individualized treatment has been suggested. Tachycardia-induced arrhythmia like atrial fibrillation-induced cardiomyopathy is another one, but then there is a chance of recurrences of atrial fibrillation, so there is a word of caution. Similarly, myocarditis, where there is a complete resolution, and we have no evidence on the MRI or GLS or biomarker, probably this is the one after a few months we can have a de-escalation of therapy. Chemotherapy-induced situation, anthracycline, there is generally permanent damage, generally not recommended to de-escalate. Whereas trastuzumab, a new anti-cancer drug which is now used, it is a reversible, and there is a myocardial dysfunction happens with this drug also, and de-escalation may be possible in this subgroup of although large number of trials are used. Alcohol-induced, again, prognosis is not clear, but heightened risk of adverse event persists even after the abstinence from the alcohol. So GDMT may be continued in most of the patient, but in certain population where there is a full recovery, we may reduce the drug. ICD therapy is another area where the question comes, the uncertainty exists on whether heart failure with improved ejection patient with normalized EF need ongoing ICD therapy. If a patient has not received any shock or he has not utilized it, then shall we replace the battery in ICD population or no? CRTD, yes, we know that we have to replace, but here again there is a good data coming from the genetic studies and from the ELR study which have shown that even in spite of that, even if they have not used it, but 2 to 5% per year may be a risk of recurrent arrhythmia. So individualized risk assessment is crucial for ICD generator replacement until more trial data is that. But it looks like it is fairly safe that we did not change the battery in certain subgroup of population. Ongoing clinical trial, as I said, with beta blocker are there. There is a good study going on at the moment of de-escalation. They tried to stop ARNI and gave only valsartan, not the two parts of the ARNI, but only valsartan, and trying to see the de-escalation therapy and whether there will be deterioration. So far, preliminary data shows it is useful. Similarly, spironolactone has been now studied here. And so clinical uncertainty remains. Consensus definition is not one at the moment. Benefit of selective as GTMT de-escalation based on risk assessment is not there. Benefit of ICD generator replacement probably needs more, but biomarkers and therapy titration probably very useful. But one thing which question comes that if a patient has modest doses of the drug, he has received 5 milligram of bisoprolol or only 100 milligram of ARNI and his ejection fraction reached 50, shall we escalate the dose or not? Or shall we stop here? There's no answer for that, but people probably, maybe this answer will come from subsequent talk. So role of CMR and GLS biomarker imaging is very crucial in deciding whether we can de-escalate the therapy or not. And I will just share with you our study which we published a couple of years ago on 800 patients. Now this year in CSI we are going to present 1400 patients. The data shows that 28% of the patients, they have heart failure with ejection fraction. This is a single center study. We did repeat echocardiogram, but 6 months follow-up was done. And what we found, younger people, patients with, or those who are particularly ARNI and SGLT2 inhibitor, more regular visits were showing a good improvement. Whereas gender differences, presence of atrial fibrillation or no atrial fibrillation, LBB, ischemia did not make much of difference in our study. So in conclusion, dear friends, what I want to say, there is a rising prevalence of heart failure with improved ejection fraction because better uses of GDMT now in clinical practice, including the 4 pillar, maybe a 5th pillar. But they are heterogeneous and dynamic with underlying different etiology and pathophysiology rendering a differential prognosis. Relapse risk could be further assessed using advanced imaging, natriuretic peptide, and also genetic testing. Current guidelines recommend sustained and indefinite treatment of improved ejection fraction to the concerns of the relapse. Partial de-escalation of GDMT might be safe in patients with low risk of relapse, although large trials are needed. Thank you very much for listening to me.